Okay, so I think I got the green light to get started. So my name is Sumona Saha. I'm from the University of Wisconsin, School of Medicine and Public Health. I'm really happy to be here with you today. This is actually my first in-person conference meeting in like 2.5 years. And although I have been doing educational talks over Zoom, it's totally different to be with people who actually can like look at you eye to eye, ask questions. So, we're going to have a formal presentation, but I want to keep this informal, and I want everybody to feel comfortable asking questions and, if talking about your own personal experiences with IBD, IBS overlap, which is what is our topic for the next 20 minutes. So just by show of hands, if you feel comfortable, I'm just curious, in this room, how many people were told they had irritable bowel syndrome or thought they had irritable bowel syndrome before they ultimately got diagnosed with inflammatory bowel disease? Just curious. Okay, so a couple, yeah. And we're going to talk about why that is the case, why were you diagnosed with something when ultimately you had something else? And we're going to talk about the fact that, actually people with IBD can have IBS, and unfortunately those two diseases can overlap quite a bit, even in the same patient. So inflammatory bowel disease and irritable bowel syndrome, they sound really similar, but they're totally two different conditions, right? So you've got IBD on one hand and IBS on the other. So they sound similar, and what's even more confusing and challenging in terms of sorting things out is that the same person can have both conditions. So let's start with irritable bowel syndrome, or IBS. What is IBS? IBS is a functional bowel disorder. What that means is that it is a condition that affects the function and the behavior of the intestines, but it's not associated with any structural abnormalities in the GI tract. It's also not characterized by anything inflammatory in the GI tract. So there are lots of symptoms that overlap with inflammatory bowel disease. So abdominal pain, discomfort, changes in bowel habits are very common and actually the hallmark of irritable bowel syndrome. So that sounds a lot like IBD, but the difference is there is nothing actually underlying inflammatory going on. And because of that, there is no permanent damage to the GI tract that arises because of IBS, as opposed to IBD, which when you have it for over time, there can be structural complications and increased risk for colon cancer. So what are the symptoms of IBS? So I've already mentioned a few. IBS symptoms can range from mild to severe, and sometimes in the same patient, right? They can be mild at some times and severe at other points in time. And they can, wax and wane. So the common symptoms of irritable bowel syndrome, or IBS, are abdominal cramping, abdominal pain, bloating, gas, mucus in the stool, diarrhea, and sometimes constipation. And sometimes in the same patient, there can be both, right? Diarrhea some days, constipation in the other. And, when you look at this list of symptoms, you say, well, hey, that sounds like what I get when my IBD is flaring, right? So there's a lot of potential overlap there. There are other symptoms that some patients with IBS endorse, so excessive gas or flatulence, nausea. Some people won't have a lot of abdominal pain, but they'll feel it in their back, so back pain and loss of appetite. What's really important to note, and as clinicians, when we're talking to a patient who has IBD and we're trying to sort out, what's causing the patient's symptoms, IBS flares or presentation of IBS is not associated with what we call red flag symptoms. And this is a list of some of the red flag symptoms that we will ask about and will listen for in the history. So rectal bleeding, not characteristic of irritable bowel syndrome, fever, weight loss, or symptoms that awaken a patient at night. So the way I ask that question is, do you ever have to wake up in the middle of the night to have a bowel movement? Those types of symptoms would not be associated with irritable bowel syndrome, but could be a feature of an IBD flare. In addition, family history of colon cancer, celiac disease, those would be red flags that a patient presenting with these symptoms of abdominal pain, change in bowel habits, that could be something other than irritable bowel syndrome. What causes irritable bowel syndrome or IBS? So no one knows the exact cause, right? You've probably have heard that today in terms of, we don't really know what causes inflammatory bowel disease in certainty, but we have a lot of potential explanations and hypotheses. So one of the leading thoughts of what causes irritable bowel syndrome is increased sensitivity in the GI tract to gas, bloating, just even liquid stool, solid stool, something we call visceral hypersensitivity. So the gut is just really primed in patients with IBS to feel everything. Gas moving through the bowel, stool moving through the bowel, liquid moving through the bowel. Now, these are processes that happen in all of us every day, really every minute of the day, right? It's happening right now. We've got things moving through our GI tract. People with IBS are just really hyper aware of that, of those sensations. And again, that's what we call visceral hypersensitivity. Patients with IBS also have been demonstrated to have abnormal transit of contents of the gut. And that means things either move too quickly through their systems or alternatively things move too slowly. And we call this altered gut motility. So it's a motility issue, it's a hypersensitivity issue. We're also learning more and more about how the microbiome affects, how the microbiome is impacted in patients with irritable bowel syndrome. And studies do suggest that patients with IBS have an imbalance between the good bacteria and the bad bacteria in the gut. And the medical term that we have for that is dysbiosis. Basically, like the bacterial proportions are off. And why do people develop dysbiosis? So this is like a really active area of research, but some of the theories are that maybe antibiotic exposure during childhood, teen years, that might change the bacterial composition of our gut. Dietary factors, what kind of food do we eat, how much processed food do we eat, did we eat foods that contained a lot of GMOs? I would say nothing has been, conclusively proven, but these are active areas of research. We also know that having a severe gastrointestinal infection can be a precursor for developing irritable bowel syndrome. So there are some patients who report having a completely normal bowel habits, never had any issues. Then they got a really severe gastroenteritis, some type of disease illness where they were vomiting, they had severe nausea, they were having diarrhea. And then even after that period of acute illness cleared, their bowel habits just never went back to normal. We call that post-infectious irritable bowel syndrome. The good news is for patients who have that type of IBS, it usually does improve over time. It can take a long time. Again, usually the acute infection has come and gone, but usually within about a year, which I know is a long time, symptoms will start to abate and people tend to go back to their baseline bowel habits. But again, sometimes having a really bad GI tract infection because it really messes up the microbiome can lead to really long-term problems with IBS. There are also, for women, some women who are extremely sensitive to the menstrual hormones, and that can be a trigger for irritable bowel syndrome. And it varies, but some women will experience more IBS symptoms in the week leading up to their period. For some women, it's during their actual menses, but for some patients, their IBS is very hormonally mediated. And then lastly, another very active area of research in terms of elucidating the cause of IBS is really starting to understand what we call the gut-brain axis. And because we think that having an alteration or a disruption of the normal communication between our gut and our brain can predispose someone to developing IBS. So what is the gut-brain axis? You may have heard this term used already today, or if you haven't, as you start researching more about IBD, you're going to hear about this, not only in terms of IBD, but also in IBS. This is a little cartoon graphic that kind of shows how there's what we call bidirectional communication between our central nervous system, which is our brain and our spinal cord, and our gut. So we all know that we've got lots of nerves in our brain. We also, interestingly, have a very rich neural network or nervous system within our gut. We call that the enteric nervous system. And those two systems communicate with each other. So basically, what does this cartoon mean and how does it relate back to IBS? Well, it means that the cognitive and emotional centers in our brain can affect the way that the nervous system in our gut behaves. So we have this intestinal nervous system, which is impacted by what's going on up here, and vice versa. What's going on down here with our nervous system in our gut can affect how our brain processes things. So you can see how this could turn into a vicious cycle, right? So if you're feeling really, if there's anxiety, if there's feelings of sadness, if there's feelings of trauma related to your gut symptoms, which is really, all of those things are very normal, very common, how having those cognitive emotional issues can impact kind of how your gut is behaving. So maybe you have more diarrhea, more gurgling, more abdominal pain. Those symptoms then can in turn continue to activate your brain centers. And again, this just turns into this vicious cycle. So future therapies, and actually even some current therapies that we're using, we have lots of centers are trying to incorporate health psychology into their treatment because we really know, we have a better understanding now of how interlinked our gut is to our brain. But if you can somehow stop that cycle of anxiety, nervousness, depression affecting the GI symptoms, you can potentially use either using cognitive behavioral therapy, hypnotherapy. There are lots of different techniques that are being explored, but that might be one way to ameliorate this disrupted relationship. So who gets irritable bowel syndrome or IBS? It's really common. So about 10 to 15% of American adults have IBS. The age rate is highest in young to middle-aged adults. So this would be like people in their 20s, 30s, and 40s. In the United States, women are more commonly diagnosed with irritable bowel syndrome. Interestingly, in other parts of the world, we have seen more gender parity, meaning men get diagnosed at the same rates as women. So we don't really know if IBS is more likely to affect women or if women are just more likely to go talk to their doctors about it and get diagnosed here in the United States. Because in other parts of the world, let's say in the Middle East, where maybe men are more likely to access healthcare compared to women, the rates are actually very similar. So again, here in the US, we do think about it more affecting women, but I always query my male patients about it too, because sometimes just the male patients are less likely to bring up some of these symptoms. Family history is also an important factor. Many patients with IBS have a first-degree family member who has irritable bowel syndrome. So a first-degree family member would be a parent, a sibling, or their child. So someone very, very close to them. And then patients with certain psychological issues, so anxiety, depression, history of childhood adversity. So that could be like childhood poverty, abuse. They have higher rates of IBS. So how do we diagnose it? This is kind of like a complicated algorithm that, represents kind of the strict criteria for diagnosing IBS. I put the Bristol stool chart in there because IBS really can span both ends of the spectrum where people can have like those stools that look more like constipation. They can also have those liquidy diarrheal type stools that are at the end of the spectrum, or they can really be somewhere where they flip-flop in between. But you can see that, although sometimes, people leave their doctor's office and say, oh, they think I have IBS, like they didn't really work me up for anything. Hopefully your clinician has thought through these criteria because there are really well-defined criteria for irritable bowel syndrome. The ones that we use most commonly in clinical practice are the Rome 4 criteria. And if you feel like, I'm being told I have IBS, I don't really believe it. I mean, you can ask your doctor to walk through the Rome criteria and say, like, which of these criteria do I meet? Like, do I actually meet all the criteria for IBS? Could something else be going on? Because again, it's not just like a garbage pail diagnosis. There are things that that we have to work through to actually get to a diagnosis of IBS. Okay, so having said that, the diagnosis can be tough because there aren't really any labs, imaging tests, or anything really endoscopically that we can hold on to in terms of making that diagnosis. Again, it's more of a clinical diagnosis based on symptoms. Having said that, often, there will be a whole process of going through multiple labs and tests, essentially to exclude other diagnoses. So often patients who are being worked up for IBS will end up getting some type of endoscopy, whether it's a sigmoidoscopy or colonoscopy. They may get some imaging done, CT scan, MRI, ultrasound. SIBO breath testing is like the testing for bacterial overgrowth syndrome, lactose intolerance testing, stool testing for inflammation. Again, diagnosing IBS doesn't require these, but it might be a process that somebody will go through to get to that diagnosis, because basically everything, it's a process of just kind of excluding other conditions that can cause similar symptoms. Really, on an exciting front, there are some blood-based biomarker tests that are being studied, and actually some of them are already commercially available. You could ask your doctor to order it to actually help with the diagnosis. I mean, if you're just not convinced, like, or my doctor says I have IBS, my symptoms are from IBS, there are some tests out there that have been validated. They're most helpful for diagnosing IBS-D, which is the diarrhea phenotype of IBS, so not so good for the people who flip-flop between constipation and diarrhea, and not so good for diagnosing IBS-C or IBS with constipation. But again, this is an exciting development in our field, because it has been challenging to diagnose IBS up until now. And then there are some stool studies that are also being looked at, which might be helpful in terms of kind of sorting out IBS from other conditions. Okay, so what are some of the complications of irritable bowel syndrome? So I think about this in two levels. Is like, how does IBS affect the person? How does it affect the family members or loved ones of somebody who has IBS? And then what is, like, having 10 to 15% of the US population having IBS, what does that mean for, like, at the society level? So patients with IBS in numerous studies have been shown to have lower quality of life scores compared to people who don't have IBS. So we know that unfortunately is the case. And then at the individual level and family level, patients with IBS may have decreased incomes because they're not able to go to work, or they go to work, but they're not able to perform their job to the fullest level, right? So they are there, but not able to take on additional tasks, things like that, that might help increase their income level because they just don't feel well. And then, of course, having IBS can pose a burden to partners and family members, because there are just going to be days that somebody doesn't feel well and can't kind of do their normal day-to-day functionings within the family. And then at the society level, there's really a lot of cost that's incurred by IBS. One is, referrals to specialists. Okay, go see this person, go see your neurologist, go see this, let's get all these tests done. So, right, that adds up. Some of these tests are inappropriate because, like I said, you really don't need any specific test to diagnose IBS, really just a good history and a good clinician. Medication costs, there's, lots of trial and error. Let's try this, let's try that until we find something that works. And then there's indirect costs, right? Government benefits, people who end up having to go on disability. There's loss of work productivity. We talked about that already. So again, for a disease that, I started off by saying, well, there's no structural damage, there's no risk of colon cancer. I mean, it is still a disease that carries a lot of burden. So that's kind of my take-home point from this slide. What are the treatments for irritable bowel syndrome? So this really hinges on us as clinicians and patients kind of honing down which subtype somebody is in. Again, the three different types are the constipation predominant, or IBS-C, the diarrhea predominant, or IBS-D, and then there's like this kind of mixed phenotype, or a phenotype where patients don't have any significant change in their bowel habits but just have a lot of pain and bloating. And so you'll see on this list maybe things that you've already tried, you're familiar with, but patients who have constipation, we tend to use laxatives. Miralax is like one that we use quite a bit because it doesn't have a lot of side effects associated with it. For people who struggle more with the diarrhea, then it's using basically agents to slow things down, things like loperamide or Imodium, Lomodal. Bile acid sequestrants are going to be things like cholestyramine, Welchol, but there are a few medicines in that family that, again, kind of help bind things up. And then for people who have more kind of the pain, bloating, and less bothered by the fluctuations in their bowel habits, and we've got specific agents that are geared towards kind of relaxing the gut. The peppermint oil, the one that's over the counter and a lot of my patients use, is called IBGuard. And then there are these antispasmodic agents, dicyclomine, it's also called Bentyl, hyoscyamine, it's called Levsin. So there are agents out there, and I think sometimes people struggle, like, I have IBS and I don't know what to do with it, but there are, again, lots of different treatments. Often it does require some trial and error, but definitely worth kind of sitting down with your provider and saying, like, hey, I already tried that, what else do you got for me? And because there are other options. All right, so now let's talk about IBD versus IBS, right? So we've kind of gone through this whole overview of what is irritable bowel syndrome. what about, like, how do we differentiate this from IBD, right? So, as I mentioned, IBD is more, IBS is not associated with inflammation of the gut, whereas inflammation is the hallmark feature of inflammatory bowel disease. And of course, everyone in this room knows there's two main subtypes of inflammatory bowel disease, Crohn's disease and ulcerative colitis. So in comparison to IBS, even I'm confusing the two. Okay, in comparison to IBS, IBD is much less common in America, with less than 1% of the population affected, right, versus 10 to 15%. So it's a much less prevalent condition. With regards to gender, IBD is about equal in terms of number, both for Crohn's and UC, between men and women. And it is characterized by visible inflammation in the intestinal lining. And visible inflammation can be seen either endoscopically, right? So when we put a scope in, the tissue lining of the colon looks inflamed, or it can also be seen on various radiology tests, right, where they can see thickening of the bowel wall. But there is going to be something visibly abnormal in patients with inflammatory bowel disease. And then laboratory studies will often also indicate the presence of inflammation. And Dr. Sagi went over some of the lab tests that we commonly use to assess inflammation. For blood tests, we're often talking about checking C-reactive proteins or CRPs, ESRs, which stands for erythrocyte sedimentation rate. And then really what we've as an entire field been moving more towards is checking fecal calprotectins because it is just much more sensitive for inflammation in the gut. So those are good ways that we can assess for inflammation. So unlike irritable bowel syndrome, which is not associated with, there are complications, of course, we just went over those, but the complications related to IBD are going to be a little bit different. So IBD patients can suffer from extraintestinal manifestations. So these are going to be things like joint pains, rashes, mouth sores. Those are not going to be common for patients with IBS. IBD patients may also experience a stricture in their intestine. They could develop a fistula. These are more common with Crohn's disease compared to ulcerative colitis. They may experience a bowel perforation at some point in their lifetime and are at increased risk for colon cancer. None of those complications are seen in patients with irritable bowel syndrome. And as I think has already been discussed today in the patient forums, is that there are lots of different treatments for IBD, and these are all geared towards reducing inflammation. And so lots of different categories. Here are the big broad ones: 5-ASAs, steroids, immunomodulators, biologics. These treatments do not translate, though, over to irritable bowel syndrome. So these are really specifically geared for gut inflammation and are geared for treating active Crohn's or ulcerative colitis. Okay, so again, talking about like overlap, right? So there are a lot of overlapping features between these two conditions, and this Venn diagram kind of shows the features that are more specific to IBD, the ones that are a little bit more specific to IBS, and the ones that overlap. And, for those of you who have either of these conditions, you can mentally in your mind say, okay, I have this one, I have that one, I have this, and then I have these ones in the middle. And you can see, again, kind of how confusing it can sometimes be to figure out, what's going on. So I mentioned already that it's quite common for a patient with inflammatory bowel disease to also have irritable bowel syndrome, and we've got several studies that support this. So there was a study from about 10 years ago. It was what we call a systematic review and meta-analysis. So it's very, very large numbers of patients. It basically pools multiple studies and tried to figure out this question of how common is it for somebody with IBD to also have IBS symptoms. And that, in this study from 2012, they found about 35%. So think about that. 1 in 3 patients who have IBD are also going to have IBS symptoms. In this study as well, they also found that there was a 4 times more likely, patients with IBD were 4 times more likely to have IBS symptoms compared to the general population. So having IBD also looks to be a risk factor for having IBS. That's basically what that means. And it looks like for patients with Crohn's disease are going to be a little bit even higher risk compared to their patients with ulcerative colitis. A more recent study this was used like a slightly different way of assessing for irritable bowel syndrome and for kind of sorting out who has active IBD because, again, there is such an overlap. So this study took it to the next level where they took IBD patients who were in remission and they validated remission by actually having them go through a scope and getting biopsies. So they took patients who had ulcerative colitis in remission and then they asked them, how many of these IBS type symptoms do you have? And basically they found that, again, about a third of patients who were in remission based on those really, strict criteria for remission, right? Having a normal colonoscopy, having no inflammation on biopsies, about a third of them had IBS symptoms. So, taking this all together, again, really, really common for a patient with IBD to also have IBS. Some of you in here may be familiar with the CCFA Partners cohort. Basically, this is a large group of patients that the Crohn's and Colitis Foundation has recruited from all over the country to participate in different survey studies. It's for those of you who are interested in participating in IBD-related research, it's a really nice way to contribute because it doesn't require study visits. You can do all this from the comfort of your own home. At any rate, this is an internet cohort, right? So people all over the country who have joined via the internet, and different surveys are administered to the group periodically. So this was a study that was done in 2017, taking, again, IBD patients who are part of CCFA Partners and asking them about possible IBS symptoms. And they found in this study about 20% of respondents who had IBD also had IBS as well. And then they looked a little bit deeper to say, okay, of the IBD patients who reported that they had IBS symptoms, what were the characteristics of those IBD patients? And they found that patients with IBD who were on narcotics had higher rates of IBS. And they also found that patients who had this overlap were more likely to experience anxiety, depression, fatigue, altered sleep patterns, to report decreased quality of life and decreased social satisfaction, meaning less likely to be doing those things socially that all of us like to enjoy. So going out with friends, there was a kind of a list of things that went into that social satisfaction questionnaire. Okay, so how do we sort this all out? So mentioned already that blood tests can be helpful. There are several ways that we can assess for inflammation by doing a blood draw, so ESR, CRP. Also, just like a CBC or a complete blood count, there are certain components of that depending on if there are abnormalities, can point us towards maybe there being active inflammation. So if the white blood cell count is high, the WBC, or if the platelet count is high, again, those can be markers of inflammation. Fecal calprotectin. You heard about this test a lot, and for those of you who have IBD, you probably have submitted a ton of these. And for good or for bad, that's probably not going to be going away because it is such a useful test for us to be able to sort out inflammation and be able to tease out whether someone's symptoms are from an IBD flare. And then, of course, imaging and scopes, they can also help sort things out. So, you take somebody who's got symptoms and we're trying to figure out, is this IBS or IBD? We may have you get blood tests, do a stool test, and if we're still not sure, either get an MRI, which is what you're seeing up there on top, and you can see the arrows are pointing to this kind of thickened area, or depending on where your disease is located, you might end up undergoing a colonoscopy with the scope findings on the left representing kind of a normal, healthy colon. Everything's kind of shiny and pink and healthy, and then you can see the one on the other side where you see those white ulcerated areas. So again, this image here on the left might represent somebody who has symptoms that's not being driven by IBD, so maybe in more of an IBS picture, whereas somebody presenting with a colonoscopy or an MRI finding on the right would be more likely to they maybe have this undertreated disease or having, be in a flare. Okay, so sorry, lots of slides about stool testing and fecal calprotectin. So again, this might be a way that we could, if you're ever wondering, God, why does my doctor keep asking me to do stool testing? This is why. So this stool testing can be really helpful in terms of kind of stratifying patients into different categories. Do they have active disease? Do they have borderline, a disease that might become active in the near future and their test is borderline, or do they have high levels of inflammation in the stool, which would suggest that they need further treatment. I wouldn't memorize these numbers because it depends on what lab your doctor's office uses, but again, just know that the fecal calprotectin does stratify into 3 groups, and we use the number to help us figure out kind of where someone is in their disease course and help us figure out next steps for treatment. Okay, so then what do we do? So, you've got somebody who's presenting with IBS-like symptoms. Of course, they have underlying inflammatory bowel disease. How do we then go about helping them feel better, right? Because that's ultimately the goal, right? Whether it's the IBD that's active or the IBS, I mean, to a certain extent, the person, sometimes it doesn't really matter. You just want to feel better. So if the issue is that there is untreated inflammatory bowel disease or undertreated disease, and that's evidenced by scope, stool studies, all the things that we've talked about, well, then, of course, the next step would be just ramping up treatment. Maybe it's talking about doing drug level testing, seeing if the dose needs to be increased, or maybe it's time to switch medications. What else could be going on? If it looks more like an IBS picture, well, then maybe we're talking about trying to get to the underlying cause of the irritable bowel syndrome. Is there untreated anxiety or depression that might be addressed through cognitive behavioral therapy, medications, gut hypnotherapy, and then could there be something else too, like small intestinal bacterial overgrowth, and that might require its own type of treatment. So, going forward, really, this is like a really confusing area, right? I probably confused everybody. But what we hope to achieve in the future, in terms of really being able to help people with IBD who also have IBS, is really understanding why do people get it. So 1/3 of patients have this overlap, but that means 2/3 don't, right? So how can we figure out who's going to get it, and are there ways that we can get at the underlying cause? Is it indeed a microbiome problem? And if it are there ways to address the dysbiosis to improve the bacterial population of the gut so that patients don't develop IBS type symptoms? Or is this more a matter of like how our brain processes pain? And is there anything that we could do at the CNS level, at the central nervous system level, so that we can reduce that hypersensitivity? So yeah, there's stuff going on in our gut, but we're not going to be thinking about it all the time and feeling that pain associated with it. And then going forward, it's again kind of figuring out the right treatments, dietary interventions, so low FODMAPs diet, that has been shown to be very effective in IBS in general. How well does it work in our IBD patients who have IBS though? And we've got to be careful, right? Because we don't want to put IBD patients on very restrictive diets because we run the risk of malnutrition, right? So we've got to figure out what is the ideal diet for patients with IBS and IBD. What about medications? Do the same medications that work for IBS patients without IBD, are they as effective in our IBD patients who may already be on 3 other meds, right? They may be on a steroid, they may be on a biologic, they might be on an immunomodulator. How does adding in another medicine for IBS interplay with the other meds that they're on? What about acupuncture? What other strategies are there out there? So, these are going to be areas that hopefully, as you come to sessions like this in the future, we'll have more bullet points. So in conclusion, IBS and IBD, they share lots of overlapping features. Don't forget that Venn diagram. But really important to note that they are 2 distinct conditions. They have different causes, they have different treatment plans, and they impact the individual differently. Also, really important to note that a patient with IBD can have IBS as well. Sorting out the cause of an individual's GI symptoms at any given time can be challenging, often will require stool testing. So fecal calprotectin is increasingly being used to help differentiate when active IBD is present and help us to then figure out whether somebody's therapy needs to be ramped up. Do they need a course of steroids? Do they need to change their biologic? Or should we be more focusing on IBS therapies? Patients who have IBD in remission and who have IBS type symptoms, they shouldn't be dismissed and by their doctor and say, well, your IBD is fine, your calprotectin is normal, don't worry about it. There are treatments for IBS. Ask for those, and be persistent because there are an expanding number of treatment options for IBS. And then hopefully future research will inform us of the most effective treatment plans for patients with IBD who have IBS, because they are a different subgroup of the entire IBS population. And I think that's all I have. So thank you.